All right, so let's just quickly go over the high output heart failure. So I'd like to think of things in terms of threes, but there's just too many good ones for high output heart failure. Let's go through them kind of quickly though. So thiamine deficiency, again, vitamin B1 deficiency, classically in patients that are, chronic alcohol use disorder, Wernicke encephalopathy, Korsakoff syndrome, usually they're going to have to give you something. Either the patient is on a very strange diet, or they're in an area where they're only having certain types of rice, for example. They have an increase in transketolase activity when you give them thiamine. So, look out for those type of things. Severe anemia also is very classic. Hyperthyroidism. So one question you might have is how do I remember this? Does this even make sense? Why do these things cause high output heart failure? Why do they cause the heart to have a really high cardiac output type state? And the reason for that, if you're thinking about these, is because in all of these situations, there's some unmet metabolic need. Okay, there's some unmet metabolic need. So in thiamine deficiency, the issue is that I can't really go through some of the steps in, getting into the citric acid cycle and a lot of my metabolic processes we'll talk about in the biochemistry videos. I can't do that with thiamine deficiency. And so my body is saying, hey, look, I need more oxygen for my electron transport chain and for everything downstream so that I can kind of speed things up. But the problem is it's not going to completely help because you need the thiamine to get through those steps. Severe anemia, it's the same concept, right? I don't have enough hemoglobin carrying oxygen to sites in my body. So my heart says, okay, well, let's compensate for that by increasing the cardiac output. Okay, so again, that's why you have this high output state. Hyperthyroidism has to do with your sympathetics. They're stimulating the heart to have this high output state. And then the AV fistula is kind of like the bonus on here. This can go a few different ways. And I've actually talked about AV fistulas quite a bit in this series, so I'm not going to go into too much detail here again. But typically, if you're looking at a question with an AV fistula, it's usually a dialysis patient question. Okay, and remember, this is where we're taking the vein and we're linking it up to an artery so that we get this engorged vein that has faster flow coming through it. And that's, ideal for dialysis. And I'm, again, not going to get into all the details here, but if that AV fistula is very large, a lot of the blood will bypass the arterial system. It won't even go to the heart. Instead, it'll just go through that, low resistance AV fistula and go immediately into the venous side. Okay, so that's the downside. If you have an aortocaval fistula where the aorta and the vena cava come together and do that, that's a big problem, right? Because all of the blood is just going to go into the venous side. It's not going to go through the heart to get pumped. So dialysis is the big one. But then when we're talking about high output heart failure, occasionally you'll see Paget's disease in here. Okay, you can just remember that. I'm going to go into more detail in this when we talk about it. But these are your classic causes. Now, when we're talking about low output heart failure, again, this is more of your cardiogenic shock. And the reason that I bring this up is because, cardiogenic shock is actually particularly high yield. And this is what can happen over time, if the heart burns out from high output heart failure, if you have, really poor ejection fraction and systolic heart failure, you're just not pumping out enough blood. And so again, cardiogenic shock is kind of like, the end result of the failure of the heart, so to speak. And that's your low output state. So a lot of these different heart failures can actually end up as a low output heart failure. And when we talk about shock, a lot of this stuff is going to make sense when we go through the shock video, right? So in cardiogenic shock, the cardiac output's low. Essentially, in most of these cases, the heart's going to be completely burned out at this point. And again, the body has been compensating for this and actually making things worse, right? Because angiotensin II has been stimulating vasoconstriction, right? So your systemic vascular resistance is going up, and it's doing all this again in response to poor perfusion to the kidneys, right? That's causing renin to be released and eventually angiotensin II. And this backup of blood on the other side of the heart is causing increases in your pulmonary capillary wedge pressure, which is a surrogate for left atrial pressure, right? We talked about that. And also an increase in your central venous pressure, which is also kind of a surrogate for your right atrial pressure. Okay, so that all that blood is getting backed up as this is happening. And so when we talk about shock and we're looking at these up and down arrows, you really just have to go through the steps to see what's happening, right? The backup of blood is causing the elevation of these pressures proximally, and then the angiotensin II, the RAS system, the sympathetics are all going to cause this increase in systemic vascular resistance in response to the low cardiac output.